surgery. And I have the pleasure to work in Kasr Al Ainy, the largest tertiary center here in Egypt, and it happens to me that I face a lot of young patients who have neglected and measuring ankle fractures. So let's start with this case of mine of 35 years old female patient with a manual ankle fracture 23 years ago, and she has anterolateral ankle pain. And let me ask the audience, who wants to go for ankle fusion? Please raise your hands. Okay. Who wants to go for total ankle arthroplasty in a 35 years old patient? Please raise your hands. No one? Destruction arthroplasty? Who wants to go for it? Who wants to go for destruction arthroplasty and realignment surgery? Okay. So to understand destruction arthroplasty, we have to answer 9 questions. How is the technique work, static versus dynamic frames, how to apply the frame, how much destruction is needed, what is the ankle survivorship after this technique, destruction arthroplasty versus sublunar osteotomy and destruction arthroplasty, combined with sublunar osteotomy for the results, what is the level of evidence and consistency, function, and radiological outcomes, and what have I learned from my patients. So let's start. How it works. So Vandenberg and his colleagues had studied animals, and they showed that if you induce osteoarthritis in the medial blocks, and then you apply a dynamic distractor like an exam frame, then this normalizes the multi-glycan metabolism seen in osteoarthritis. And Yang and his colleagues found that distraction creates the space allowed for proliferation of chondrocytes. So the hypothesis in human candidates is that mechanical unloading allows for eliminating axial and shift force, allows for repetitive growth in the cartilage. Intim and his colleagues made a study in human beings, and they measured the density of subchondral bones pre and post distraction. And they found a constant decrease in the subchondral bone density throughout the follow-up period. Here you can see here in this case we can see the subchondral sclerosis present, and the subchondral sclerosis has nearly disappeared after 2 years follow-up. So the mechanism of action is unloading of the joint, neutralizing the axial and shear force, allowing for cartilage healing, and normalizing the proteoglycan metabolism, and removing of the subchondral bone with subsequent decrease in density. The second question is static versus dynamic frame. So in his study, Vandenberg and his colleagues compared the static and dynamic frames, and they found that static frames cause severe muscle atrophy, and in non-articulating frames there is complete depletion of proteoglycan metabolism with poor functional outcomes. Articulating frames allow for cyclic changes in intra-articular pressure, and these cyclic changes improve the local environment for cartilage healing. So the third question, how to apply this frame? It's very simple. You have a tibial part with 1 or 2 rings perpendicular to the longitudinal axis of the tibia. You have a foot piece. You must put it along the longitudinal axis of the calcaneus, and you can have a half frame of a foot piece. And the most important thing is to put your hinge along the right axis of the rotation of the ankle joint. And how to do so? You get a reference wire, you put it in the tables, and you, in the AV view, you just put it from the tip of the lateral malleus to the tip of the medial malleus, and then you adjust your hinges according to this reference wire. How much distraction is needed? So Vandenberg again and his colleagues recommended more than 5 millimeters of joint distraction. Fragment in a cadaveric study recommended 7 millimeters of joint distraction, and as a rule, avoid distraction acutely of more than 10 millimeters to avoid neurovascular affection. So what is the ankle survivorship following this technique? In a retrospective study, which included 144 patients, the patients had distraction arthroplasty for ankle osteoarthritis. The median follow-up was 4.5 weeks. And what was interesting, we found that the survival rate of the ankle joint was 84% at 5 weeks follow-up, and at 10 weeks follow-up it was about 60%, with overall failure rate of 16.7%. And what they conclude that this technique is a good alternative to ankle fusion of arthroplasty, but it has a decreasing efficacy over follow-up time. Another nice study, meta-analysis, where 31 studies were included. In all the studies, there was improvement in visual analog scale and American Orthopaedic Foot and Character Strength score. The failure rate was 9% in patients with less than 5 years of follow-up, and the failure rate was 28% in patients with more than 5 years of follow-up. And again, it appears that this technique loses its efficacy after 5 years. So, ankle destruction versus supralenar osteotomy. In this study, this was a comparative study between the two techniques. The study included 32 patients in the joint destruction group and 41 patients in the supralenar group. It was a retrospective study with average follow-up time of 32 months. And we found that the functional results between both groups were comparable. But supralenar osteotomy is superior in correcting the alignment of the ankle and the mechanical axis, thus preventing further progression of osteoarthritis. So what if we combine supralenar osteotomy with destruction arthroplasty? So in this study, it was a respective comparative study between both groups, patients who have supralenar osteotomy alone and patients who have supralenar osteotomy plus destruction arthroplasty. And all the patients had a high tailor tilt angle. You know, this is a normal, to those who don't know, this is a normal tailor tilt angle. It has to be from 0 to 2 degrees. And this is the abnormal tailor tilt angle. And the problem with the tailor tilt angle is usually a matter of soft tissue problem. It's usually you can feel in severe inverse forces, you can feel lateral structures and contracted medial structures. So in this study, it concluded that supralenar osteotomy plus destruction osteoblasty is superior in correcting and maintaining the tailor tilt angle to normal values with subsequent improvement in the clinical outcomes. So, what is the level of evidence and consistency of the results throughout the study? This is a schematic review conducted in PubMed using the wall destruction and ankle and arthroplasty, and 171 articles were found. And they were looking for the level of evidence supporting the destruction arthroplasty. And they found that most of the studies were level 5 evidence. In this table, these are the only studies that were level 2, 3, and 4. And they concluded that the high quality studies were needed. Another systematic review from UK, it includes 15 studies who met the inclusion criteria, and they found inconsistency in the function and radiological findings throughout the studies. And this is controversial somehow. We found a lot of studies that go through destruction arthroplasty, but in this systematic review, they found inconsistency in the function and radiological findings, and they concluded, and I quote, that destruction arthroplasty is not an effective treatment option for ankle arthritis and should not be used in clinical practice at all. And this is what I quote. So what to do? I don't know. So we started our study, and our first case was done with Professor Ahmed Samir here in 2022. We included patients with ankle arthritis secondary to malunited ankle fractures. We excluded patients with bad skin conditions and controlled diagnostic patients who have complete destruction of the ankle cartilage by diagnostic scope. We have done about 15 cases till now, with follow-up at least 6 months. The management protocol was staged with the first stage of diagnostic ankle scope to assess the articular cartilage, last realignment osteotomy, last destruction arthroplasty. Second stage, after 3 months, we removed the frame and we did a diagnostic ankle scope to see what happened, what is the effect of our technique. And we continued to see the healing pattern of the cartilage over and over again in our cases. So let me start with case 1. This was the case with the X-rays in the beginning of the lecture. In the first scope, she had this huge ulcer on the tibial side. But look at it after the destruction. The whole ulcer is covered with fiber cartilage. The second case, the other case, was a young youth who has neglected beyond for about 6 months. And you can see that we have again and again this layer of fiber cartilage, and we continue to see it in all our patients. And the early results, the patients improved from a mean anti-American foot and SAT score from 45 to a mean of 75, and they're doing well. So what have I learned from my patients? And this is for me the most important question. First of all, if you want to do the destruction arthroplasty for ankle arthritis, you have to do a diagnostic scope first. And if you find that the joint is totally destroyed like this subcondylar bone and there is no cartilage, please abort and go for ankle fusion. In case of ankle alignment, you cannot rely on the disruption arthroplasty alone. You have to realign your ankle. You have to restore your mechanics. And this is what we did for our patient. We realigned her ankle and worked here in the disruption arthroplasty. A similar frame for me is a better frame. I use a frame with medial and lateral hinges, a single tibial ring, a single foot piece, a single trachinal piece, and force. It is much simpler for the patients. And lastly, in my opinion, this technique works. So my take-home message is the answer to our 9 questions. This technique works by decreasing the axial loading to cartilage and optimizing the can metabolism. Use the hinges frame. Please bolt the hinges in the plane of the axial rotation of the ankle joint. Distraction is between 7 and 10 millimeters. The efficacy of this technique decreases after 5 years, and the survivorship is only 6% at 10 years follow-up. Supralateral osteotomies are superior to correcting the mechanical axis, and supralateral osteotomies combined with destruction arthroplasty has superior results to supralateral osteotomies alone. We need more high-quality studies in this field, and in my opinion, when this technique is combined with ankle realignment procedures and arthritis correct patients, it works. Thank you.